The CD will come through the video. Yes. So which one talk on Tics and whatever. Tics, one problem is I had a case of Tics. That's why I asked this particular thing. I don't know how to treat that fellow. And the mother and the grandmother and grandfather were more worried about the problem than the boy itself. So I thought we must know something about it. Is there any medical management? Because most of us are veterinary, we don't do any endoscopic surgeries and all that. So anything medical management for that. So what do you get?
Thank you.
Kesavan, with 8 years of experience in neurosurgery, currently working as Associate Consultant in a neurosurgical team headed by Dr. Shyam Sundar Krishnan across various hospitals in Chennai. Education, MBBS, Coimbatore Medical College, Tamil Nadu, MS General Surgery, Madras Medical College and R.G.G.K.Savan, Chennai, Tamil Nadu, MCh Neurosurgery, Madras Medical College and R.G.G.K.Savan, Chennai, Tamil Nadu. Experience, Medical Officer, Public Health Center at Nagapattinam, Trichy and Coimbatore districts. Assistant Professor, Omanjura Medical College, Chennai. Assistant Professor in Neurosurgery, Institute of Neurosurgery, Madras Medical College and R.G.G.K.Savan, Chennai. Skills, with 8+ years of experience in the field of neurosurgery, proficient in diagnosing, assessing, planning treatment and operating upon complex and atypical neurosurgical pathologies.
Good evening to Ananda. And today's my topic is hemifacial spasm and tics and trigeminal neuralgia and facial palsy. Next. First we will start the hemifacial spasm. Hemifacial spasm is a condition of intermittent, painless, involuntary and spasmodic contractions of muscles innervated by facial nerve in one side of the face, may be limited to the upper or lower half of the face. During hemifacial spasm, excess lacrimation may be present. It usually begins with contraction of the orbicularis oculi muscle and slowly progress to involve the entire half of the face and increase in the frequency until eye impact. And this is a hemifacial spasm video. First, starting with the orbicularis oculi muscle, and gradually it will progress to the buccal muscles. This is a typical hemifacial spasm. Followed by weakness of the facial muscles.
Terminates or
Slowly it will terminate, sir, but again it will recur. Causes vascular compression syndrome is the most common etiology. This compress the facial nerve, and second cause is idiopathic, and tumor from the cerebellopontine angle tumor and posterior fossa tumors is compressing the facial nerve will cause this problem, and follows the Bell's palsy also sometimes. Yeah, this is the facial nerve palsy. This is hemifacial spasm. Trigeminal neuralgia is a fifth nerve, compressing the fifth nerve.
facial,
So, and other clinical blepharospasm, it mimics the hemifacial spasm. It associated with organic brain syndrome. Blepharospasm is notorious for disappearing when the patient presents for medical evaluation on effort of alerting, but may be elicited by asking the patient to gently close the eyes and rapidly open them, following which blepharospasm may occur. Usually involves HFS involves the ocular muscle and buccal muscles. Blepharospasm only involving the ocular muscles. And facial myoclonus, continual facial spasm, which may be manifestation of intrinsic brainstem glioma or of multiple sclerosis. Hemifacial spasm usually caused by compression of the facial nerve at the root exit zone by a vessel, most commonly anterior inferior cerebellar artery, either in the pre or post meatal region, and posterior inferior cerebellar artery and superior cerebellar artery and tortuous vertebral artery, and the cochlear artery and dolichoeptic basilar artery and ICA branches. And rarely veins have been implicated. And in typical HFs, already seen that onset in the orbicularis oculi muscle and progressing downward over the face. The vessel impinges on the anterior caudal part of the 7th and 8th nerve complex. In atypical facial spasm, beginning in the buccal muscles and progressing upward over the face, and the compression is the posterior part of the 7th nerve. And vessel contacting the root zone of the vestibular nerve may cause associated with vertigo, whereas tinnitus and hearing loss may be result from the cochlear nerve compression. Infrequently, benign tumors in the like cerebellopontine tumors and cysts in the cerebellopontine angle, multiple sclerosis, arachnoid adjacents, and osseous skull deformities will be the cause for hemifacial spasm. During evaluation, in typical cases, all diagnostic workup is negative. Most patients who have the MRI of the posterior fossa, CT is less sensitive, and vertebral angiography is usually not performed if imaging is normal. The neurovascular compression is responsible for HFS, usually cannot be identified in the angiography. Next. And management of hemifacial spasm is generally it's a surgical condition. The early mild cases may be managed expectantly. Carbamazepine and phenytoin are generally ineffective, unlike the condition of the trigeminal neuralgia. Local injection of the botulinum toxins may be effective in treating HFS and also for blepharospasm. Baclofen has been advocated in some cases, but it is not very effective. And surgical management, many ablative procedures are effective in HFS. However, this leaves the patient with some degree of facial paresis. The current size of HFS is microvascular decompression, where the offending vessel is physically moved off the nerve by a sponge. Usually we are using Teflon, but Teflon is very thin, so Evolon also used for the interposition as a cushion. Next. Post-operatively, there may be episodes of mild HFS, but usually begin to diminish within 2 to 3 days post-operatively. If severe spasm that does not reduce suggests failure to achieve the adequate decompression, and reoperation should be considered. And surgical results of the MVD depends on the duration of the symptoms. If shorter the duration, the better prognosis, and the younger age have good prognosis. So trigeminal neuralgia, also called as tic doulorex. This is the most excruciating pain known to humanity. The pain typically involves the lower face, jaw, and also sometimes it affects the area around the nose and the eye. This intense stabbing electric shock-like pain is caused by the irritation of the trigeminal nerve, which sends branches to the forehead, cheek, and lower jaw. Usually limited to one side of the face. This pain can be triggered by an action as routine or a minor as brushing the teeth, eating, or just touching air or anything. Attacks may begin in the mild and short, but if left untreated, trigeminal neuralgia can progressively worsen. This is the trigeminal nerve distribution areas. Trigeminal area, the ophthalmic nerve supplies the eye, upper eyelid, and forehead. The maxillary division supplies the lower eyelid, cheek, nostrils, and upper lip and upper gum, and the mandibular area. The third branch controls the sensation in the jaw, lower lip, lower gum, and muscles of the chewing. Anticonvulsivant medication is the first treatment of choice, especially in the V2 and the V3 divisions. Surgery can be effective option for those who become unresponsive to medications, who suffer serious side effects from the medication. And surgery is predominant in the ophthalmic division. Two types in the trigeminal neuralgia, primary and secondary. Primary trigeminal neuralgia has been linked to the compression of the nerve, typically in the base of the head, where the brain meets the spinal cord. This is usually due to the contact between the healthy artery or vein and the trigeminal nerve at the base of the brain. This places the pressure on the nerves as it enters the brain and causes the nerve to misfire. And the secondary trigeminal neurosis causes the pressure on the nerve from the tumors and multiple sclerosis, cyst, and facial injury. Next. Symptoms often first experienced along the upper or lower jaw. So many patients assumes that have a dental abscess or a dental pathology. Some patients see the dentist and actually have a root canal performed. And the pain, even after that process, patient realizes that the problem is not dental related. The pain of the trigeminal is classified into two types, type 1 and type 2. Type 1 is very high intense pain, throbbing, sporadic and burning shock like pain, but trigeminal type 2 is it's a constant burning, aching and less intense than the type 1. It's trigeminal neuralgia tends to run in cycles. Patients often suffer long stretches of frequent attacks followed by weeks, months or even years of little or no pain. The usual pattern, however, is for the attacks to intensify over time with shorter pain-free periods. Some patients suffer less than one attack a day, while others experience a dozen or more in every hour. The pain typically begins with the sensation of electric shocks that culminates in an excruciating stabbing pain within less than 20 seconds. The pain often leaves the patient with uncontrollable facial twitching, which is why the disorder also known as tic doulorex. These are the even mild stimuli can trigger the trigeminal neuralgia. Touching the skin slightly, washing, shaving, brushing your teeth, and blowing nose, drinking hot and cold beverages, and encountering a light breeze, and applying makeup, smiling, and talking, all are triggering of the trigeminal neuralgia. The MRI brain can detect if a tumor or multiple sclerosis affecting the trigeminal nerve, and a high resolution thin 3-dimensional MRI can reveal if there is a compression caused by a blood vessel, and newer scanning techniques can show the pressing the nerve and may even show the degree of compression. Compression due to veins is not easily identified under the scans, and usually diagnosed based on the description of the symptoms. This is the MRI of the trigeminal neuralgia patient. Here the superior cerebellar artery compressing the trigeminal nerve. Here, this is the superior cerebellar artery compressing the same patient having compressing over the trigeminal nerve. After surgery, the superior cerebellar artery separated from the trigeminal nerve.
Now in this artery, the contact here is moved up.
And initially medical management is advised. The carbamazepine and oxcarbazepine, carbapenem, lamotrigine and valproate and phenytoin, and along with baclofen.
It's normally for intractable hiccups.
Yes, sir. Baclofen. Yes, sir. Baclofen. It's a treatment for and local procedures and reasoning procedures. It's a percutaneous glycerol rhizotomy and percutaneous radiofrequency rhizotomies, and percutaneous balloon compression over the Gazarian ganglion, and stereotactic radiosurgeries. This is a glycerol rhizotomy video. And 1% lidocaine is administered in the 2.5 centimeter from the angle of the mouth, and spinal needle is directed towards the medial ipsilateral pupil line and 2 centimeter anterior to the external auditory canal, directed towards the foramen ovale.
So basically, the thing comes from here and we enter here. So
these are the supraorbital V1, V2, 5.1, 5.2 and 5.3. A gloved hand is kept inside the patient mouth during the needle advancement to prevent the entry into the oral cavity, and lateral and submental view demonstrates the course of the needle placement through C-arm. This is the lateral view. The trajectory is 1.5 cm posterior to the dorsum sella. This is the sella. So while taking lateral images, that the frontal floor should be in the same plane. That is the true lateral. That is the sphenoid sinus and dorsum sella, and this is posterior clinoid region and bastion. Line joining the posterior clinoid and bastion is rival line. So trajectory with target posterior to the dorsum sella is indicated. The sella is here and posterior to the sella. This is a foramen ovale, the white elliptical. So this is the submental view to demonstrate the spinal needle at the medial border of the foramen ovale. So both lateral and submental view minimize the surgical error.
So we have landmarks by which we go. We mark the front of the ear here, mark 2 centimeters side of the lip here, and mark the pupillary line there. We type these 2 points. And we make the patient lie down so that the spine becomes perpendicular. The neck goes up. Then we keep just directing towards this eye tree. So we just land directly on the foramen of the forehead. And we reach the.
Not that we can get absolute alcohol.
Yes. So absolute alcohol, glycerol, and radiofrequency ablation are the 3 options you have. The problem with absolute alcohol compared to glycerol are 2. One, alcohol, when we inject the patient, we put the needle in lying down position. When we inject the drug itself, we bring the patient forward and then we don't want it to tickle backwards. If it tickles backward, it will go along the clivus and weaken all the cranial nerves down the line. Glycerol, even if it does, it will not do any damage. Alcohol would. So they will be very particular that you keep the head down once they inject. So that was the risk with absolute alcohol. It destroys everything. Alcohol, 100% alcohol. Compared to glycerol. Glycerol has got a beautiful effect is that it produces only nephrology. It doesn't produce numbness at all. Patient you see, he will say he can feel both sides, but if you take a needle, he will say the prick is blunted. Whereas in absolute alcohol, the sensation also may be impaired. In radiofrequency ablation also, you end up, and with balloon, it's even worse. You have a complete sensory error. So cheap options is glycerol and alcohol, glycerol and alcohol. In costlier options, it's radiofrequency. So I personally like glycerol because it's very cheap, quick, and you get what you want, and the results are quite good. Till 2015, I used to do only MVDs, but now what we do is that we strategize patients into probably 3 groups. If you have an eye involvement in the pain, we definitely do MVD surgery. If the eye is not involved, why being you don't want corneal sensory loss? We want him to feel pain in this eye. So we do an MVD. But if it is V2 and V3, then we prefer to give them a glycerol block or a alcohol or radiofrequency. But if the eye is involved, we definitely go for surgery as an option. Secondly, suppose you don't get a loop, a compressive loop on the scan, then it is better to go for a block because you don't know whether your surgery is going to work or not. Technically speaking, they say even if you don't find a loop, you can go ahead, handle the nerve, that itself the pain disappears as a concept. There will be a vein compressing, and if you push the vein away, this will go off. So I keep the option of surgery as a second line rather than the first line in the treatment.
How long will be this
Carbenzepine you can give forever. There is no restriction as such.
as long as the patient gets relief?
One patient should get relief. It should not have a toxic dose of 1200 milligrams you don't reach, and you do not have side effects in and load. Some people just 200 milligrams is enough for them to feel giddy, fall off.
Maybe it's only giddiness.
Giddiness, main is giddiness. And secondly, liver function should not have any issues. These are 4 things we need to be sure about. And of course, any anticonvulsant is that bone marrow issue. So all those things don't happen. You can put the patient on carbenzepine, and if they are comfortable, that's fine. But sometimes you may have breakthrough pains. Sometimes a drug holiday will help. You give up, stop all the drugs for 1 week, 10 days, or maybe 2 months if possible. Then you can restart, the effect will be better. But otherwise, very good.
So you don't need to give administration.
You can give a break. Like in Parkinson's, you can give a drug holiday. Sometimes you use. But first line of treatment for trigeminal neurology is medicine.
In some patients, they can go on with Saxazone.
I had a patient who we just did a block who was on for 20 years. 20 years well controlled, just 20 years well controlled on 400 milligrams. Okay, the moment they increased it by 200, he started having problems. And then he couldn't bear the drug. And he couldn't stop it, he had to reduce it, they changed it, he went to gabapentin, pregabalin, amitriptyline. And it didn't work out. And then he came and we did a blog. And after 20 years, he put in the Google review or something, 20 years I've got relief and everything. Poetry is no form. And he went to Vijayawada, got the Kanakaduri, But what I'm saying is that the relief is so good.
Yes, I myself have it.
Okay, but your control, don't touch it. As long as you're happy with it, don't touch it. Whatever medicine works, I think medicine is the first thing. Even for hemifacial spasm, I usually advise them carbamazepine to first go. Though we know it will fail, but till it fails, it can get the benefit of. But these are not functional. These are all. These are not exactly structural problems, right? They're, I don't know how to put it. There's no tumor there. It's a normal vessel which is there for everybody. Only with this person, the normal vessel is creating a problem. So why unnecessarily touch them unless it is necessary? Immediately act on something. Then take the minimalistic approach. Why do MPD? I personally think it works better leaving a block. If the block failed twice, let it fail once. After 6 months, whereas you have very good foot again. Fail acha, then we do an MPD. I'm a surgeon here, very happy to operate. So, but let us look at outcomes and that is the way I think. And also the trigeminal neuralgia is also to be picked up correctly. If you have, so I was not to that, just hold on a little bit. So you have to recognize what is trigeminal neuralgia. It's a clinical finding. This MRI is not going to answer your question. If you got a typical trigeminal neuralgia, the pain will not cross the jawline. The angle of the jaw and the jawline. It should not cross it. Trigger points are classical. Here, here, here. These are trigger points. Night time, he will sleep well. He will say no pain in the night. It's a classical finding. If he says he's got pain in the night, there is something else. Or it's atypical. If you don't know the answer, it's crossing the jawline, it's going somewhere else. Unless he's having no choice or very ill, you can try a block, but there's a good chance it may not work. So you should classify. And glossopharyngeal neuralgia is another more very big. Some patients come purely weakly. There is a lower jawline pain alone. You should be very cautious. One dental issue, re-rule it out before you touch it. Second thing is the pain if it's crossing the jawline, ask him if the swallowing pain is there. It's there because glossopharyngeal neuralgia. So that's a totally different ballgame. Only surgery is the option. So all these things we should be absolutely. So atypical trigeminal neuralgia is something you need to definitely say no to before you touch a typical neuralgia.
What you can get this intermittently, right?
Yeah, there are many forms it may come at. Patients are completely alright sometimes. The last patient who I talked about, he comes to me, sir, pain இப்போ இல்லை ஆனால் நான் உள்ள வரும்போது சுல்சுல்னு அடிச்சது சார் அப்புறம் போயிடுச்சு சார் இப்போ நான் உங்களை பேசிட்டு இருக்கும்போது இப்போ வருது சார் அப்படின்னு பண்ணிட்டு. This is one kind of patient who comes to me.
More than the pain, if it does that vague sensation, kind of you know something's not right between two halves. Right?
Pain is a constant.
It will be constant.
It is a constant factor. That is, you may have episodic or it may be constant. But pain is the bottom line. There is nothing without pain. Then it's not typically general. And the pain should, constant pain fellow will come into your OP like this. The AC will say, in your office he will say this, he will close his eyes, he will protect his face and talk. So typically he will come and say.
Pain or the articles.
That is again atypical.
Exposure to
because the vagus nerve supply comes there. Vagal branches.
vagal branches.
Molecular branches are not options.
But that also happens with the pain.
You can give it because it will work across the board.
Servologan, right?
Start with amitriptyline, age-old drug, simple drug. They'll get good sleep, be comforting. And also, if there is some psychological component, it will be there for 100%. It will definitely be relieving the pain for a long time. So, that's not so bad.
Gamma knife radiation.
So there are patients who go for gamma knife, but the gamma knife takes 1.5 years to act. It's not going to immediately act, it's going to take some time to act. Some people may get an immediate effect also, and it's going to take time. But if they are able to bridge with the drug till that point of time, then it will start working. But again, radiating the brain for a benign condition, I'm not sure what is the logic behind that. And another thing is definitely MRI is important to rule out MS plaque. MS plaque is something we should be careful about, because if you are having an MS plaque, so always when you ask for an MRI for a trigeminal neuralgia, vascular loop should ask for vascular compression. It is vascular neurovascular conflict. You should ask for that conflict. The second thing, because as referee doctors, if you do this, we don't have to ask for an MRI. Patients get angry. So ask for a neurovascular conflict. There are special sequences to tell us that. It is very important. The second thing is MS plaque is unbred. The point where they give the gamma radiation, that is where the MS plaque will be. Post radiation, MS plaque inflammation. So you should ask for a MS protocol if you are going to interface. Betterwise, do it off. We miss it sometimes. So, and sleeplessness is not a symptom of training. Being sleepy.
The once needle position is confirmed in the two views, and the omnipack is infiltrated to know the correct position, and needle tip has not penetrated the foramen ovale with injection. Attempted penetration of the foramen ovale required higher doses of sedation and necessitating the pharyngeal mark airway, and the omnipack is injected. And often CSF will drain from the spinal needle, confirming the position of the Meckel's cave, that is the trigeminal cistern. Needle is withdrawn after the anhydrous glycerol is administered, and the patient is after the procedure, patient has to sit in the flexed position for 2 to 3 hours post-operatively. And surgery to the trigeminal is microvascular decompression, the microsurgical exposure of the trigeminal nerve root, and identification of the blood vessel that compressing the trigeminal nerve. Decompression may reduce the sensitivity and allow the trigeminal nerve to recover and return to a normal life and pain-free condition. And while this surgery, it is most invasive surgery and requires the opening skull through a craniotomy, there is a small risk of decreased hearing while affecting this 7th and 8th nerve complex, and facial weakness and facial numbness and double vision and stroke and death. This is a microvascular decompression video. This is a 42-year-old female came with trigeminal neuralgia, right side pain. Here the opposing vessel is petrosal vein that compressing the trigeminal nerve in the cistern. This is the trigeminal nerve and this is the petrosal vein. Patient responded incomplete to a medical management, and the suboccipital craniectomy done in the right suboccipital craniectomy, and cisterna magna is exposed to, and CSF was let out, and gentle cerebellar retraction was done, and visualization of the ICA is the anterior inferior cerebellar artery. This is, and this is a trigeminal nerve, and this is a petrosal vein. The white structure is trigeminal motor road. that root entry zone towards the brainstem is seen. That is the trigeminal nerve's motor root and sensory root. And the root entry zone is separated from the petrosal vein gently, and arachnoid adhesions are cleared. The petrous vein and the trigeminal nerve adhesions are seen in the superior aspect of the trigeminal nerve. Here the offending vessel is petrosal vein. Usually artery involved in this, ICA and superior cerebral arteries are the most common arteries. Vein is very rare. After separating the petrosal vein from the trigeminal nerve, the Teflon patch is interposed between the two. This is a Teflon sponge. To reduce the recurrence, the Teflon sponge is placed in between them. The neura is closed. Next. The trigeminal neuralgia will not cross the opposite side, and it will not disturb the sleep. And also, if any pain in the inside of the mouth, it is not due to trigeminal neuralgia. Maybe clausopharyngeal neuralgia will be there, so it will not affect the inside of the mouth. Only peripheral aspect of the mouth will be affected. And the facial palsy, it again divided into central and peripheral. Peripheral divided into nuclear and facial nerve lesion. The next. And this anatomy, the 7th and 8th complex coming through the petrous bone, and it's giving branches to the greater petrosal nerve and nerve to stapedius and cauda tympani, and it comes out from the stylomastoid foramen and dividing branches to and giving branches to the cervical and temporal regions. So previously, so here. Above the cerebellopontine angle, it is a UMN lesion, and it's from nuclear under the facial nerve. It will be a LMN patient. Whenever the guttural petrosal is affected, reduce the lacrimal secretion and nasal secretions, and it's when affecting the cauda tympani, it will affect the anterior to the 2/3 of the tongue sensation, and when stylomastoid foramen is affected, the muscles of facial expression will be affected. And central facial nerve palsy is also known as supranuclear palsy. The cortical representation for the facial movement occurs in the motor strip along the lateral aspect just above the most inferior opercular portion of the precentral gyrus. And central palsies are confined to the lower face due to the bilateral representation of the upper face area, and it will spare the facial expressions. The motor nucleus of the 7th nerve is located in the pontomolar junction, and 7th nuclear palsy will affect all motor function of the 7th nerve, and tumors affecting the 4th ventricle, the medulloblastoma, will affect the 7th nerve, and Millet-Gubler syndrome, example for that. There is ipsilateral abduction palsy with contralateral limb weakness, and facial calculus is affected when the tumor in the fourth floor of the fourth ventricle.
And
And
see this patient with a facial or palsy, I know the picture would post that, but this would be like upper motor, lower motor differentiation. All these two are protected because they may have a cross palsy. So one cross palsy, whereas one hand would deviate. So it may be a brainstem lesion then. So facial or palsy typically will present a Bell's phenomenon now. Because the right side or left side is weakness in the middle, then it's a cross deviation. So in that case, better to go for weakness from one side also. And if you feel any doubt, don't hesitate to do an MRI.
Tourette syndrome the brain படம் வர அப்படின்னு பாட்டு அப்புறம் போட்டு
Feel worried, just get it done. And here also check out the same.
Common cause of the element facial palsy is Bell's palsy and Ramshagen syndrome, also known as herpes zoster oticus, and temporal bone fracture. In birth itself, it's a atypical condition, bilateral facial palsy seen in the Mobius syndrome and facioscapulohumeral or myotonic muscular dystrophy. In otitis media, the acute otitis media, facial palsy usually improves with antibiotics. With chronic suppurative otitis media, intervention is needed, and neoplasms, the cerebellopontine angle, slowly progressive weakness we have seen, and most are the either benign schwannomas of the facial nerve or auditory nerve, and the malignancies in the temporal bone will affect the facial nerve, and parotid tumors involve some branches but spare the others. Next. The neurosarcoidosis affects the most commonly affected the seventh nerve, and diabetes affects 17% of the patients are more than above 40 years old, and it's a 4 to 4.5 times relative risk developing facial palsy than non-diabetics. And other diseases, Lyme disease, Guillain-Barré syndrome, and Klippel-Feil syndrome, isolated fourth ventricle, all give element palsy. Bell's palsy is a idiopathic peripheral facial palsy. By definition, it's not due to known causes. It's a true Bell's palsy. It is idiopathic and is a diagnosis of exclusion. Most cases probably represent a viral inflammatory demyelinating polyneuritis, usually due to the herpes simplex virus. Severity graded by the House and Brackman grading scale. Its symptoms are usually viral prodrome is frequent, the upper respiratory tract infection, myalgia, hypoesthesia, dysesthesia of the trigeminal nerve, and diarrhea is the prodromal symptoms. And paralysis may be incomplete, and it is complete in 50% of patients. The incomplete is type 1 and complete is type 2. Usually exhibit the distal to proximal progression. Motor branches, then cauda tympani, and stapedial branch, then geniculate ganglion. Symptoms are usually ipsilateral, and during a herpes zoster infection, the vesicles develop in 4% of patients, then 2 to 4 days of the onset of the paralysis, and during the recovery phase, excessive lacrimation may occur due to aberrant nerve regeneration.
Shingles vaccine can be given for these.
Only before only, so after now we have to wait and yes sir. And associated symptoms with Bell's palsy is facial and retroauricular pain, and dysgeusia, and hyperacusis, and reduced hearing in 17% of patients. And surgical decompression is controversial, and if it is a complete facial nerve degeneration without response to nerve stimulation and progressive deterioration, no clinical improvement after 8 weeks, surgery will may be effective. And Bell's palsy management, general measures, eye protection, and avoid bright light, and medical management, prednisolone, and improves the chance of complete recovery at between 3 to 9 months. Acyclovir may help. And prognosis, essentially all cases show some recovery. The extent of recovery, 75 to 80% cases will recover completely, 10% partial recovery, and remain or 10 to 15% will not recover. If recovery begins by 10 to 21 days, it tends to complete recovery. If not, until 3 to 8 weeks, it will be partial recovery will be there. If paralysis is complete at onset, the 50% will have incomplete recovery. If incomplete paralysis at the onset that do not progress to complete paralysis, it will complete recovery will be there. Incomplete paralysis at the onset of progress to complete, it is an incomplete recovery in 75% of patients. And worse prognosis associated with more proximal involvement and hyperacusis, decreased tearing, and age more than 60 years, diabetes, hypertension, and oral facial and radicular pain. This is a Ramsay syndrome. Symptoms are more severe than the Bell's palsy. Antibody titer to varicella zoster virus will rise. This patient have high risk of facial degeneration and incomplete recovery will be there. And surgical options. This is a 7th 8th nerve complex schwannoma. It's ice cream cone appearance. It's the cerebellopontine schwannoma. And tics and Tourette disorder.
Facial palsy, main thing is get an MRI if you suspected tumor, especially if you have hearing issues. Facial palsy with cross palsy. Facial palsy with trauma. Head injury coming, patient had a head injury, fracture mastoid. Patient was doing well, got discharged. After 7 days, facial weakness is not started facial palsy. If he starts, immediately start on high dose steroids, up to 16 milligrams can start and wait for it to improve. If it doesn't improve, then get at least a CT mastoid. I think it is involved at that stage. The other thing is to think of long up before 6 months.
So, Mike.
3 to 4 months. If the patient doesn't recover in 3 to 4 months, then the plastic surgery involved. Because if the nerve can be bypassed or use some nerve transposition or look for other methods of rehabilitation.
Tics and Tourette syndrome. It's a sudden, repetitive, non-returning, stereotyping motor movement or vocalization involving the discrete muscle groups. They can be classified as either motor or vocal, or simple or complex. Simple motor tics typically sudden, brief, meaningless movements or sounds that usually involve only one group of muscle. Sometimes it mistaken for muscle spasm. Simple vocal tics usually having simple sounds, and the complex motor tics typically more purposeful appearing movements that last for longer. And complex vocal tics involves words and phrases and may include repetition of what was just heard or said or socially inappropriate manner. This is etiology for Tourette syndrome. Next. What? This is due to thalamic interference only. So basal ganglion caudate and putamen and globus palatal substantia nigra. The thalamus will block the undesired movements to the motor cortex. The motor cortex will any problem in the thalamus, it will cause uninhibited reflexes will be sent to the motor cortex. So that's why the atypical movements are there. So simple tics are motor tics. So eye blinking, head jerking, and shoulder shrugging, and finger flexing. And the vocal tics, simple vocal tics are throat clearing, sniffing, snorting, barking, or grunting sounds. And the complex tics, distinct coordinated patterns of movements involving many muscle groups, smelling or touching the objects, flapping the arms, hopping, and touching the nose. The simple complex motor tics. And complex vocal tics are using different tones of voice, coprolalia, echolalia, and palalia. And coprolalia is performing upstream orbital gestures. Echolalia is the imitation of serious movement that have just been observed. Palalia is the repetition of any movement or behavior that patient just performed. And during diagnosis, there are no blood or lab imaging tests available to diagnostics. Both motor and vocal tics must be present, but not necessarily at the same time. Tics occur at least several times a day, nearly every day, or intermittently for at least a year. Tics cannot be caused by medications or other substances or other medical conditions, and often patient receives a formal diagnosis long after their tics are present. Many people with tics are self-diagnosed after their parents or relatives or friends hear about their parents from the others. So, Tourette syndrome is a chronic disorder of tics that has been both motor and vocal tics. It is usually inherited and starts between the ages of 6 and 10 years old. When Tourette syndrome tends to progress and becomes more severe during puberty and surfaces in adulthood. The criteria occurred is both multiple motor and one or more vocal tics have been present at some time during the illness, although not necessarily concurrently. The tics occur many times a day, usually in bouts nearly every day or intermittently throughout a period of more than 1 year, and during this period there was never a tic-free period of more than 3 consecutive months. The disturbance causes marked distress or significant impairment in the social, occupational, and other important areas of functioning. The onset is before 18 years of age usually. The disturbance is not due to the physiological effect of substrate or general medical conditions. Typically, the disorder begins with a simple motor tic of the face, blinking. The tics persist and generalize to other parts of the body. The action analysis is the typical thoughts. Eventually, vocalization is ensures the typically explosive in nature. Other symptoms of thoughts are stuttering, sticking on the tongue, smelling the objects, holding the chest, body, compulsive touching, and bruxism and echopraxia. There is no cure for Tourette's, but the condition often improves the late teens or early 20s. It's a lifelong chronic condition, but it's not a degenerative condition. People with Tourette's have a normal life expectancy, does not impair their intelligence. And the neurobehavioral disorders that are associated with Tourette's is such as attention deficit disorder, the ADHD, and obsessive compulsive disorder, depression, generalized anxiety, panic attacks, and mood swing can persist in adult life throughout the severity of its use. Medication may be taken to minimize the impairment of cognitive Tourette's, but it's not useful. Behavioral treatments, awareness training, and competing response training can be used to reduce the tics. Although it has not been shown to reduce the tics, can help a person with Tourette's better cope with the disorder, the social and emotional support.
Thanks, Dr. Kesavan. Now, I request Dr. Rao, senior member Dr. Raghuram. Yes, I have a moment to visit. Yes, Dr. Please come. Last question.